Welcome to CareTalk, your virtual home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix.
John, we're going to talk about coronavirus again today. I want to focus this time on home care. What role is home care playing in treating COVID-19 patients?
Well, I think what's interesting, David, is that we've been arguing for a while at CareCentrix and on this podcast that home care and care in the home can provide a lot more capacity, not just to the healthcare system to pull people out of nursing homes and hospitals that shouldn't be there and prevent them, frankly, for getting readmitted. But in this particularly critical time when we need more access to the best resources that hospitals can provide, ICU beds and super specialists and ventilators, the opportunity to actually leverage home care and telehealth and technology to give us more flexibility to grow the base of how many people we can serve is absolutely mission critical. I mean, I think we could create 20% more capability in the system if we can actually take advantage of more of the opportunities that we have.
John, I think you're making an important point. I want to make sure I understand it and can underscore it, which is that it's not so much that you can treat the critically ill COVID patients in the home. It's rather that there's a whole bunch of other people out there in the healthcare system, in institutions, in hospitals, and in post-acute facilities and so on that could be treated at home. We need to get them out of those places right now into the home. They could be treated, and therefore the people that have coronavirus can be taken care of in the hospital as needed.
Yeah, step back a second away from COVID for a moment and realize that we could probably cut readmissions. The average Medicare eligible, 50% of the time is going to go back to the hospital for be readmitted within 180 days of discharge. We could probably cut that number by a third quickly by making sure that the vulnerable elderly people have the resources they need at discharge, have the information they need. We can also cut admissions and readmissions to nursing homes. We are in unprecedented times. If we are going to solve the challenge we're going to have of taking care of all of the most vulnerable targets of this ugly virus, we need to protect people over 65. If they can be cared for outside of hospitals and nursing homes, we need to do that. And home health care can be absolutely essential. We've shown by cutting readmissions to hospitals and nursing homes, by reducing nursing home length of stay, that it can be done by leveraging home health, by providing better information to patients and their caregivers, and by sort of doing care traffic control during that last mile. We need to find more flex and more access to those high need resources in the hospital and those beds, because we do have a fixed amount of supply of hospital beds in the 5,000 hospitals we've got in this country. And I think home health care to the home, and providing that access to tools and information and support will give that.
John, we're putting a big emphasis right now on making sure the U.S. doesn't follow the track that Italy is following. It's not clear to me that we're being successful just yet. But one of the key lessons coming out of Italy, as I understand it, is that the hospitals themselves became a major source of infection. So infecting healthcare workers, but also infecting all those people that were not there for coronavirus treatment. And I think that partly what you're talking about is, sure, we're freeing up the capacity, but you're also preventing people from getting coronavirus and then bringing it home along with them. So there's every reason, to be able to go with the recommendations that you're making. I want to ask you a little bit about, what's happening.
I think David, building on that though, I think one of the more troubling things we're hearing but don't know is that there are a lot of asymptomatic people who are spreading the disease at a time when we don't have enough tests, and frankly don't have enough tests to test even all the symptomatic patients. Well, we absolutely don't have enough tests for those who are showing no symptoms. And so by moving more care away from more acute clinical settings, we actually protect the more vulnerable patients. The other thing that's quite different between the Italian population, the Italian and the demand on that system, is they have substantially more folks who are elderly, who are the biggest targets of this nasty virus.
John, I was going to ask you something different, but let me circle back to the question about testing at home. Now, I understand that, ideally, great, we could test people at home. There have been some discussions about that. I'm also concerned about whether that's really ready for prime time. I know we're talking about encouraging people to be, treated at home, especially for non-coronavirus. What's the state of the art for testing now? Is that something where the home
Well,
is?
no, I think no, no. There are very reliable molecular tests that this virus was sequenced in China very successfully. We know the RNA that is associated with this virus. We can identify it. Roche and others have tests that do work. We're bringing a lot of private capacity online. The molecular tests that where you actually sequence the gene, the RNA rather, of the virus, are getting better and better. In fact, I think there was an approval this morning. Roche can do the test in 4 or 5 hours. It usually takes 24 hours to 48 hours to get it back to the hospital. I think the announcement today was that there are molecular tests where you can actually get an answer in 45 minutes, but that we are capacity limited by not just the complexity of this test. That's easy to knock, but the reagents that are used to kind of feed the test and supply it'll take some time for the supply chain to catch up. And I believe that at least in the near term, only those symptomatic or critically ill are going to be, or those with very clear symptoms that mirror the ones we know, are going to get access to those tests, even though there is a substantial amount of testing coming online. I also think you're going to see a lot of innovation around sequencing and flexing the system. But unfortunately, we need those tests now. We need not the ability to test hundreds of thousands, but multiple hundreds of thousands of people if we're going to get the best view of the scope of this disease. Because until we can actually test more of the population, it's harder to tell where the hot spots are. There's a different kind of test, sort of serologic, the kind of blood tests that you'd take or that you sort of get put on a simple panel that are more consumer driven, which are not as perfect a test. Those I think are also going to be coming online. But again, the demand is now there. They've been produced at scale in China, and I think US is catching up, but we're not there yet. Once those both are available, I think consumer access to serologic tests that'll look a lot like a pregnancy test. And then you will also, simple on a panel, the FDA will get through that. You'll also see a substantial expansion in kind of the private testing around molecular. But until those are available at scale, I don't think you're going to see a lot of tests at home. What would be ideal is before people get critically ill, you'd be able to screen them for COVID at home. But I think we're months away from the capacity to be able to do it effectively at home.
Let me ask a kind of a prosaic question, which is not one for further down the line, but for right now. I know that hospitals either have canceled or are canceling elective surgery to free up the capacity, as you said. But I was speaking with somebody just yesterday whose son just had shoulder surgery, and he's supposed to be having intensive physical therapy, but he's not having any physical therapy right now, and it's going to probably affect his outcome longer term. Should somebody like that, are there options for those people to revert to home care even if they hadn't planned on it? Is it a bad idea are there even therapists that come to the home? Is it a bad idea that one of those people might be, one of these asymptomatic infected? I mean, how is the system dealing with these issues?
Look, we're not medical professionals, and we're kind of healthcare geeks with attitudes. But I think that the best thing we can do is to take advantage of the CDC guidelines and some of the smarter folks, the virologists like Dr. Fauci, who are all giving very clear advice that this is a moment for social distancing. And I certainly wouldn't recommend that for physical therapy. That's not a critical need. Could potentially put you in touch with folks who are spreading even unintentionally. There are a lot of really good tools to self-teach physical therapy online, or that their doctor or therapist or orthopedist could recommend. And I would recommend self-care until we've got a better handle on a very popular phrase, flattening the curve, which is lowering the momentum of this virus infecting more people. So the first question around that you need to answer is, should we start with social distancing? And if that's yes, then you have to adapt to it after that. Once we're through the sort of speeding up the spike of this virus spread, we can return to provide more access to direct occupational therapy, physical therapy, behavioral therapy in the home. But right now, I think that where you can avoid contact, you should. I mean, and again, I'm just basing that on the CDC guidelines and frankly, the experience of Singapore, Taiwan, Australia, places where they've actually cracked the curve of the COVID spread.
John, let's talk about something we are qualified to talk about. How about intergenerational relationships? What do you, anything like this that comes through is going to have an impact on society, and you see some real differences kind of between older and younger folks and how they're reacting and what they could do to one another. What's your current take, and how do you think this plays out?
Well, I think you've got a plus and a minus there, David. I mean, and you see it with your own family that you're having more family dinners at home, and I love the fact that your kids are focusing on how grateful they are to be together. The world is too much with us, running so fast. This is creating an interesting pause moment for families to get together. But there's no question that there's also, from a behavior change perspective, adults are more quickly responding to the command of social distancing than at least on the press would have you believe many younger folks are. And one of the more jarring statistics in one of the hot spots in the U.S. is New York, that half of the ICU cases that are related to COVID are people who are under the age of 65. This is a very dangerous virus for all ages and needs to be treated as such. And so I guess, again, the message on that one is tell your kids, tell them from a distance, but tell your kids to keep their distance from their friends and everyone else. But there are moments of grace even in this period of craziness.
Well, John, there was a friend of mine who has a young daughter, and she said that she actually, what we should do with the COVID virus is they should actually go to other people because they want to give it to other people. I think with the implication that they won't have it. Let's give it to somebody else rather than keeping it around the house. So I think if only it were that easy, we could pass it around like a hot potato.
No, this is something as a society we just need to take gravely seriously right now. It's a threat with a much more dangerous profile than I think most people realize. We do not, to your point, want to be the Lombardy region of Italy, the hospitals overrun with people they can't actually care for.
Yeah. Well, John, there's holidays coming up, Easter and Passover in particular. And I think, families that typically get together during those times, and including ours with the extended family, are now, thinking now about how to, use remote conferencing and other kind of techniques to, to celebrate those in a different way. Yeah. Well, I wasn't making any product endorsements, John. You can use.
We all got to adapt to the situation on the ground. FaceTime, Zoom, cell phones, whatever Android, Google Hangouts, whatever works. But we are all going to have to adapt.
Good. Well, John, I'm sure there'll be more to say, but let's wrap up this edition of CareTalk right now. I'm glad we had a chance to talk about coronavirus and the relationship with home health. More to say about it later. But for now, I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Keep your distance. It can make a huge difference in how many people actually are going to survive this horrible virus.
Hey there, listeners. Want more Care Talk? There's more to be had in our other episodes, so be sure to look for those and subscribe to Care Talk on your favorite service.